So today I'm going to talk to you about septic acute kidney injury and try to discuss some of the insights that have developed about our understanding of this condition over the last 10 years and perhaps allow you to think about it in a different way. Now, I'm sure you understand that the kidneys fail quite frequently in hospital patients and in ICU patients, and that kidney malfunction is a really major problem in the management of acutely ill patients everywhere in the world. Sepsis is a particularly important problem because about 50% of acute kidney injury in ICU is sepsis associated, and the vast majority of septic ICU patients develop some degree of acute kidney injury. But despite the frequency, the importance, the bulk of morbidity associated with it, we have a limited understanding why and how sepsis induces acute kidney injury, and that is because it's incredibly difficult to investigate the kidneys in human beings in a sufficiently invasive and detailed way to allow you to understand what might be happening. It is for this reason that we have initially undertaken a process that was dedicated to understanding at least the hemodynamic components at a vascular renal level of what might be happening in a large mammalian model of sepsis as a way to guide us into understanding septic acute kidney injury. In Australia, of course, we've got 110 million sheep and 25 million people. So the sheep is the favored large mammal for investigations. And this is a model that we have. This is a chronic implantation of flow probes. The animals have stage surgery. First we open the chest and we put something, a high accuracy transit flow probe around the pulmonary artery. Then we open the abdomen and we can put a flow probe around the left renal artery. And these flow probes are highly accurate. Transit time flow probes are highly accurate, validated to 1 mil per minute. All of that is connected to computers to download the information every heartbeat. The operation is concluded. The animals are allowed to recover. And 2 weeks later, then they're brought onto the laboratory. They're reattached to the flow meters. And then we initiate the experiments. We observe for a period of time, and then we induce sepsis by the administration of intravenous gram-negatives. This is an E. coli that we obtain from a patient that we've grown over time, and we know quite reliably at a given dose will induce changes in the animals. Now you can see here what happens when you administer gram-negatives. And you can see that the phenotype of the animal is not too dissimilar to what happens in human beings. So you can see the heart rate becomes immediately unstable, and then the animal becomes very tachycardic. The cardiac output is unstable initially, and after about 2 hours it starts going up, and the blood pressure is unstable, and then it becomes low, and you have what we would currently call in the intensive care unit a hyperdynamic, vasodilated physiological state with tachycardia, high cardiac output, low blood pressure, and that's what you would call septic shock. Now, in human beings, all of that can be measured, but in human beings, you cannot measure renal blood flow. You don't have a transit time flow probe around the renal artery, and measuring renal blood flow in man continuously is currently impossible. But in these large animals, we have the ability to measure renal blood flow. And you can see that as the phenotype develops, from the very beginning, whether you support the animal with the administration of a vasopressor agent, we call that noradrenaline, that's norepinephrine in America, or if you just observe and you administer a vehicle, there is a very striking change in renal blood flow. And it's not ischemia. It's hyperemia. So there is a significant increase, almost a doubling in renal blood flow in the animal. As this is happening, the animal becomes anuric. So we have a very interesting situation where we are simulating sepsis and septic shock with a clinical phenotype in an awake animal that simulates what we see in human beings with severe sepsis. And when we have anuria, oliguria in the animals, that happens in the setting of hyperemia. And of course, if you've got a low blood pressure and your renal blood flow is increased, then there can only be one explanation. Your renal conductance, or which is the inverse of resistance, your conductance has gone up or your resistance has gone down, whichever way you want to describe it. There is functional renal vasodilatation. So once we simulated the phenotype of what we see in human sepsis with gram-negatives, renal blood flow was not decreased, was increased, and the renal vascular resistance was decreased with simultaneous oliguria and loss of GFR. So in the early period of experimental hyperdynamic sepsis, the loss of GFR is not induced by ischemia in the septic animal, but rather in a setting of hyperemia and vasodilatation. And this is very important because it shows that the function of the kidney is now dissociated from flow. I'm sure lots of intensive care clinicians are familiar with the concept of VQ mismatched. Well, you have an FQ mismatch. There is a loss of filtration while the flow is up. We then challenged ourselves. We said, well, this is a short-term model. We are looking at what's happening at the beginning. Is this a sustained effect? Is this then going to go from hyperemia into ischemia? And well, we're just looking at a particular period at the beginning. So we took this model to 48 hours, and we do that by giving an initial bolus of gram-negatives and then administering a continuous infusion of gram-negative at a lower dose. And you can see that the mean arterial pressure falls dramatically, the heart rate goes up, and it is sustained. The cardiac output goes up quite markedly, it doubles, and it's sustained at 48 hours. The total peripheral conductance, or the inverse of the resistance, goes up, so there is systemic vasodilatation. And what happens is the creatinine goes up quite strikingly. This is in micromoles per liter. You use milligrams per deciliter, but this will be about 3 milligrams per deciliter or so. So there is acute renal failure. The urinary output plummets to almost zero. And as all of this is happening, which defines the onset of severe acute kidney injury in this septic animal receiving continuous intravenous gram-negative organisms, the renal blood flow has trebled. And of course, similarly, the renal vascular conductance has trebled. So now you're taking the model to 2 days, and again, in this septic situation, you have a vasodilated state. Well, we asked ourselves then the next question, so why is this happening? Why are we watching the loss of function in the setting of hyperemia? And obviously, one of the things you want to do is to look at whether there are histological or immunohistochemical or apoptotic changes that might explain cell injury in this setting. And again, this is the model with creatinine clearance going down, plasma creatinine going up. And when you look at the animals and you look at the histology in normal controls compared to the septic animals, comparing to animals that are allowed to recover, there is no difference. That is, the histology of these animals with profound acute kidney injury, which continues for 48 hours, is essentially indistinguishable from normal. There's no structural change to be seen. But there are changes in some of the gene expressions related to nitric oxide synthase, and that would make sense in the setting of vasodilatation. There is an increase in the expression of the genes for iNOS, the inducible form of nitric oxide, in the cortex, but not in the medulla. So the cortex appears to be unique in its behavior. And the endothelial nitric oxide is also overexpressed in the cortex during this period of vasodilatation. The neuronal nitric oxide is overexpressed in the cortex. The hypoxia-inducible factor, on the other hand, is not significantly altered. So you have renal vasodilatation, you have hyperemia, you have overexpression of nitric oxide synthase, You have clear hemodynamic changes, and the expression of nitric oxide synthase correlates with the degree of vasodilatation and increase in renal blood flow. And there really isn't much apoptosis at all. So how can this be? So we are lost function, we've got hyperemia, we've got no evidence of significant apoptosis, with no evidence of cell necrosis, no evidence of acute tubular necrosis. What the hell's going on? How can this happen? So let's think about the glomerulus for a moment. Very simple thinking about it. There's the afferent arteriole, there's the glomerular tuft, and there is the efferent arteriole. It is possible that you can lose ability to filter through various mechanisms that affect the filtration pressure inside the glomerulus. How can you decrease filtration pressure inside the glomerulus? Well, one way to do that is to have afferent arteriolar vasoconstriction. But if you had that, how could you have hyperemia, given that the glomeruli are the end of the renal circulation? However, you can also lose filtration function and filtration pressure if you have afferent arteriolar vasodilatation, but you have even greater efferent arteriolar vasodilatation, such that the pressure inside the glomerulus, which is controlled by the relationship between the two vessels, actually decreases. So it is possible that in severe sepsis, the kidney fails because there is vasodilatation, but in particular, there is efferent vasodilatation, which is greater than the afferent vasodilatation. And we see a similar phenomenon when we give ACE inhibitors to patients. Particularly when we're talking about vascular surgery, people have got renal artery stenosis, where there is, with efferent vasodilatation, a dramatic change in the relationship between the two vessels. So initially, at least, it might be that in septic acute kidney injury, you have hyperemia, afferent vasodilatation, even greater efferent vasodilatation, loss of pressure in the glomerulus, loss of filtration pressure in the glomerulus, and loss of GFR. If that was true, then the logical physiological next step would be that if you gave a selective efferent arteriolar vasoconstrictor, then you ought to make things better. And that's somewhat paradoxical, but if this was true, then you should be able to do that. There is, of course, an efferent arteriolar vasoconstrictor, and that's angiotensin II. So you can do physiological studies. You induce sepsis, the way we just showed you before, and you randomize the animals to receive vehicle or angiotensin II. And if you give angiotensin II, of course, the blood pressure goes up, as you can see there. The cardiac output goes down a little bit because of the increase in afterload. The heart rate goes down a little bit. The total peripheral conductance goes down because you've induced vasoconstriction. And of course, the renal blood flow must go down because the last gate in the flow, the efferent arteriole, has just been shut. And so that's exactly what happened. And of course, the renal conductance must also go down because you've just induced renal vasoconstriction. But this is what happens to urine output. There is a dramatic increase in this model of hyperemic sepsis if you give angiotensin II. And it's not just a little bit of an increase, it's a 5 to 10-fold increase in urinary output compared to vehicle. And of course, the creatinine clearance is almost completely restored during the intervention with angiotensin II compared to vehicle. So this supports the logic that efferent arteriolar vasodilatation may be an important mechanism for the loss of GFR in gram-negative sepsis. So this is a proof of concept situation that in early experimental hyperdynamic sepsis, efferent vasoconstriction may help. But of course, all of you, by now would be thinking, now that's nice, that's very interesting. We don't treat sheep. What's happening to human beings? And that's very, very difficult because, of course, as I said to you before, the measurement of renal blood flow in man is problematic. So what do we know about renal blood flow in septic man? So you start going back into the literature. Let me take you back to 1973 when ethics committees did not exist. And you can take 11 patients with intra-abdominal sepsis and put a renal vein catheter while you were infusing para-aminohippurate and inulin to allow to calculate the clearance of the two, which allows you estimation of renal plasma flow as well as GFR. And what was found in these patients was that the total renal plasma flow was actually 154% of normal, and it was tightly correlated with cardiac output. And in fact, there is some data in a few volunteers from circulation in 1967 showing similar findings. So both of these studies suggest that, in fact, human beings with sepsis or sepsis-like states may well be similar to sheep. Now, if you are a bit of an obsessive character like myself, then you keep on hunting back to see if there is more information. This is from Homer Smith, the doyen of American nephrology. He took patients and gave them pyrogens, which is, again, those were the days of no ethics committees. I guess if he did that today, he would be arrested. And what he found was exactly the same thing, that there was a marked increased renal blood flow, reduction in arterial blood pressure, and an increase in cardiac index. And it's very much like in the sheep. And this is kind of cut and paste from what he did, the administration of pyrogens to human beings and typhoid vaccine to human beings. And it's quite extraordinary to read what went on in 1945 in the hospital with patients dropping their blood pressure to 60/40 and bradycardia developing while they were mucking around and having a good time measuring a variety of hemodynamic and renally relevant things. And I particularly like this bit where the patient is quite sick and the response to this is really quite frightening. And they questioned the patient concerning a member of a family against whom she was known to harbor a strong grievance in order to restore blood pressure. Those were the days, huh? Anyway, enough of the history of medicine. But what you can see is that the GFR is falling, but the diadrast clearance, which is a measure of renal blood flow, shows that after initial instability, there is a significant increase. The cardiac index goes up, the GFR filtration fraction falls, the GFR falls, but the renal blood flow has gone up. So we don't know much about what happens in human beings because renal blood flow is so difficult to measure. I'll come to magnetic resonance imaging in a moment, but it looks like they're really not that different from sheep. Now, magnetic resonance imaging affords us the ability to estimate renal blood flow quite accurately by doing phase contrast magnetic resonance. Of course, that is extraordinarily complex. You have to transport a critically ill patient who's intubated, who's developing or has developed acute renal failure, put them in the magnet for an hour, do all of these studies, and it is very, very challenging. But at least for that period of time, you can both use phase contrast magnetic resonance imaging to measure cardiac output and renal blood flow. You can take a sagittal view of the renal artery and look at it head on. You can create a zone of interest, and with every pulse of flow, there is a change in the phase of the magnetic activation. It's phase contrast, and you can calculate the integral of that change over time, and then you can look at what the blood flow is. And this is a series of patients Until number 8, they're all with acute kidney injury in the setting of sepsis, and then 2 patients with the hepatorenal syndrome type 1 in HRSS 1 and 2, and that's a reference of normal volunteers. First of all, let me just show you the cardiac index of these patients, and you can see that there is extraordinary variability in human beings that were taken to the magnet at that time. Some were hyperdynamic, some were normodynamic, and one was hypodynamic. I'm putting the arrows there for the 2 patients that were very hyperdynamic because I will return to that in a minute. When you look at the renal blood flow index adjusted for body size, you can see that overall in these patients that had established renal failure, now the actual renal blood flow is not what we've seen so far, but it has actually gone down. However, in the 2 patients that were hyperdynamic, the cardiac output was high and the renal blood flow was high. So there appears to be a relationship between your overall hyperdynamic or overall cardiac output state and what's happening to the kidney. But what is particularly interesting here is that the renal blood flow had a relationship to the cardiac index, as I mentioned before. The calculated renal vascular conductance had a relationship with the systemic state of vasodilatation, but the renal blood flow was dissociated in human beings, again, from the function of the kidney. And this is a recurrent observation, that renal blood flow does not predict in these studies what the function of the kidney is. And the dissociation from flow and function is what we often call shunt. So, this is all very interesting. The kidneys aren't working. Renal blood flow does not appear to be a major problem. There may actually be an excessive global blood flow, but flow is dissociated from function, and histology is dissociated from function. And all of these things do make you understand that there may be efferent arteriolar vasodilatation, but there may also be intrarenal shunting. That is, the blood comes to the kidney, but then it goes somewhere else beyond the glomerulus. So, we set out to do studies to assess whether shunting was taking place. We measured a variety of variables. Again, this is the flow probes being inserted. This is the sheep in our lab being measured. But this time, we wanted to look at microvascular flow. And you can do that by inserting specific probes that have got the ability to measure the laser signal in small areas, cubic areas of kidney, and they do laser Doppler measurement of flow. And you can also insert probes that allow you to measure intrarenal oxygenation. And so now you have an animal, you can infuse gram negatives, you can measure total renal blood flow, but now you can measure intrarenal oxygenation, and you can measure microvascular flow in the cortex and in the medulla. Again, we've got the same model. The cardiac output has gone up, the heart rate's gone up, blood pressure has gone down, there is vasodilatation. The global renal blood flow has gone up, the renal vascular conductance has gone up, there is loss of creatinine clearance, there is oliguria, all the model of acute kidney injury, but this time we're able to look at cortical and medullary perfusion and oxygenation. And you can see here that the cortical perfusion remains quite nicely, and the cortical oxygenation goes up a little bit. It's nicely maintained. However, the medulla behaves differently. There is a decrease in medullary flow and quite a significant decrease in medullary oxygenation. So Knowing global renal blood flow is, if you wish, knowing nothing at all, because it's what's happening inside the kidney, and it's a redistribution of flow inside the kidney that appears to be particularly provocative and may be related to the loss of function. Okay, hang on. Didn't we just learn in medical school that the glomerulus is the end point of the renal circulation? How can you shunt? Well, maybe the anatomy we learned at medical school is not true. There are now several studies that have been published in the literature that show that there are shunt pathways in the kidney. That in fact, the efferent arteriole can come and enter the glomerulus and exit as the efferent arteriole, or blood can just continue on a side branch and bypass the glomerulus and enter the vasa recta. This is another illustration of the efferent arteriole and the ability to skip the glomerulus. Again, this is the efferent arteriole. It can go into the glomerulus, or it can split, and it can go straight into the vasa recta. So shunt pathways, again, there's a beautiful picture, this one as well, of the efferent arteriole. So shunt pathways, another one, and another one. So they exist. So there is actually an anatomical basis through which there can be intrarenal shunting of blood flow away from the glomerulus. So you can actually have hyperemia, but it doesn't give you increase in glomerular filtration and increased function. And there are other studies, and in fact, when you become obsessed with this stuff, you can find that a German anatomist called Ludwig had described in sometime in the past these problems. So we're able to show that there are changes in perfusion and oxygenation in regional aspects. Despite an increase in total blood flow, medullary perfusion and medullary oxygenation was adversely affected. And of course, these views and these observations suggest that, in fact, septic acute kidney injury may well be a disease of the microcirculation. Okay, but then what's driving these processes? What are the factors that are responsible for these changes? And it may well be that inflammatory factors are responsible for these changes. And certainly in animal models, the blockade of the activation of some of these inflammatory pathways like tumor necrosis factor with soluble receptors is able to abrogate the loss of function without any hemodynamic systemic effects, suggesting that there are local effects. If you remove the ability of the mouse to produce nitric oxide, that doesn't do the trick. So it's something much more complicated. It's something that relates to other pathways of inflammation that are involved in the process of sepsis. And more recently, work dealing with toll-like receptor, which is activated by endotoxin, we're able to show that you can actually significantly change the renal function even though you don't affect the hemodynamics. So the blood pressure is not affected, and yet you're able to support and maintain creatinine clearance and urinary output with toll-like receptor blockade. So let me conclude my presentation by telling you that global renal blood flow in sepsis may well be high, initially driven by vasodilatation. This is certainly what we see in large, awake animal models of gram-negative sepsis, and this is what the evidence available in human beings supports us to believe. What drives this vasodilatation and the dysfunction that is associated with it remains unclear. However, in septic acute kidney injury, there is much to suggest that inflammatory pathways are responsible for what we see. We know now that in animals for sure, and probably in humans, there is a dissociation between global flow, function, and histology. These events, this level of dissociation, may well suggest, and it does suggest, that within the kidney there is shunting during sepsis. And that shouldn't come as a surprise, for we know there is shunting everywhere else in sepsis. It would be extraordinary if the kidney was the only organ that didn't have that. And although the whole of intensive care literature, the whole of our efforts, the whole of our therapeutic endeavors have been obsessed with trying to fix the macrocirculation and increase renal blood flow, they may well be futile and pointless because the problem is in the microcirculation. Thank you very much for your attention.